Today I will be talking about the clinical management of hypercalcemia. I am Professor Narsingh Verma and I will be talking about hypercalcemia. Hypercalcemia is a condition in which concentration of calcium goes very high, and as you know, calcium is a very important element because it is involved in bone strength as well as muscle nerve function, and it is also involved in second messenger in most of the physiological mechanisms. Calcium being very important, nature has designed so that calcium absorption is very complex. Usually, the calcium absorption is controlled precisely because the calcium, when remains inside the cell, it will activate the cell, and depending upon the type of the cell function will start. If it is a muscle, it will contract, and if it is a nerve, it will conduct, and if it is an endocrine gland, it will secrete. So such is the importance of calcium. That is why the nature has very well regulated absorption of calcium via GI tract, and whatever calcium absorption occurs, even then remains controlled in the particular cell organelle and not free inside the cell. If it remains free inside the cell, then it will create a lot of problems. That is why nature has maintained it very, very stand. The calcium levels in the bloodstream are mainly regulated by three hormones: parathormone, vitamin D, which is also called as a hormone, and calcitonin. And we know that parathormone is secreted by the parathyroid gland, while the calcitonin is secreted by the thyroid gland. The vitamin D is considered as a hormone, and this is finely regulated by the synthesis in the skin and further converting into active forms in the liver and finally by the help of kidney. Hypercalcemia can vary in severity and chronicity. The hypercalcemia usually affects 0.5 to 1% of the general population, not very uncommon, but because of the difficulty in diagnosis, most of the time it is not taken into account. Hyperparathyroidism is the main cause of hypercalcemia, and because of the hyperparathyroidism usually develops, the signs and symptoms of hypercalcemia can be remembered by the phrase moans, stones, groans, and bones. I will explain every one of them. So by definition, hypercalcemia is corrected total serum calcium value above the upper limit of the normal range or an elevated ionized calcium value. The skeleton contains 99% of the total body calcium, and the remaining 1% circulates throughout the body. So basically this 99% which in the skeleton can take part in the regulation as well, because it can come into the circulation and vice versa. Among the circulating calcium, 50% is free, that is ionized one, 40% is protein bound, and 10% is complex to phosphate, citrate, bicarbonate, sulfate, and lactate. Most of this is complexed by phosphate and citrate and bicarbonate in the bones and teeth. Only elevation in the free calcium are associated with symptoms and signs. So we are concerned with only that free calcium because that will create symptoms, and that is important because it is taking part in most of the reactions. If we try to classify the hypercalcemia, then according to the level of corrected total serum calcium value, the hypercalcemia is classified. It is usually classified by the level, and it is mild hypercalcemia when the corrected calcium level is more than 10.5 milligram per deciliter to less than 12 milligram per deciliter. So in between 10.5 to 12 milligram per deciliter, we say it is mild one. Moderate hyperglycemia when the corrected calcium level is between 12 to 14 milligram per deciliter. And we say severe hypercalcemia when a level greater than 14 milligram per deciliter is there. So more than 14 is the severe one, producing very severe symptoms. Corrected calcium is 4 milligram per deciliter minus serum albumin into 0.8 plus observed calcium. So that is the formula used to find out the corrected calcium. So calcium levels are by that. The distribution of circulating calcium is described here. The calcium in body fluids is either present in ICF or ECF. In ICF, it is basically cytoplasmic free calcium, and the cytoplasmic free calcium is that calcium which governs most of the reactions. Or in ECF we are concerned because that is the value we are measuring. It is 8.5 to 10.5 milligram per deciliter. Then it is again divided into three: the ionized one, the complex calcium, and the protein-based calcium. The ionized one is more important because we are concerned about that value, because this is taking part in most of the reactions and required for physiological reactions as well, mechanisms as well. 4.4 to 5.2 milligram per deciliter is the value, and complex one is 4.4 to 4.6 milligram per deciliter, and protein-based calcium is 0.7 milligram per deciliter. Clinical features of hypercalcemia. When hypercalcemia develops, that is the value reaches more than 12, then or more than 10.5, then what happens? It can be completely asymptomatic. That is most important, that there can not be any symptoms, and the symptoms may appear very late, and that is why most of the time diagnosis is difficult. But when the levels further rise, then the symptoms appear. Symptoms of the central nervous system are important, and they are basically lethargy, depression, psychosis, ataxia, stupor, and finally into coma. So starting from lethargy and depression, leading to psychosis, ataxia, and even coma. Neuromuscular effects can also be seen in the form of weakness, very, very common symptom, but it is also present in other diseases, so cannot be pathognomic. Proximal myopathy and hypertonia may be seen when the value rise further. Cardiovascular effects can be in the form of hypertension, bradycardia, and shortened QT interval in ECG. Shorted QT interval is one phenomena which is seen in other conditions as well, so we cannot say that ECG is diagnostic. Renal effects can be seen in the form of stones, decreased GFR, polyuria, anorexia. This anorexia is caused because of the systemic effect, and stones and decreased GFR are the renal effects. Eye findings such as band keratopathy, nausea, vomiting, constipations are GIT symptoms, and they are again overlapping to so many diseases, so we cannot say it is because of hypercalcemia. Systemic metastatic calcification, this occurs in conditions where the cause is something else, and that has produced hypercalcemia. So this is the bones, stones, groans, and psychic moans. Here the symptoms are listed in the form of the CNS symptoms, in the form of confusion, depression, fatigue, renal symptoms like urination, thirst, renal calculi, and maybe GI symptoms in the form of anorexia, nausea, vomiting, constipation, abdominal pain, and pancreatitis can also occur, and the presentation of hypercalcemia can be as vague and confusing as this patient looks. That is why it is difficult to diagnose sometimes. Normal calcium balance and hypercalcemia is shown here. You can see here from ECF, 500 milligram of the calcium can be exchanged from the bones, and that exchange is important because it is again governed by so many hormones, and because of that the bones can lose calcium to the ECF and they can also gain calcium from the ECF. So whatever calcium is taken in the diet, that is absorbed by GI tract and that goes to ECF, but you see that most of that is lost in the feces. So the calcium absorption is very, very less. It depends upon so many factors, but the most important is calcium binding protein. And this calcium binding protein is again hormone dependent, but these proteins are synthesized like other proteins in the liver, and the calcium binding proteins are required for the absorption of calcium. That is why the calcium absorption is less in GI tract, and most of the calcium which is taken in diet goes wasted in the form of feces. Then whatever calcium in ECF is present, again that goes to kidney, and reabsorption in the tubules occurs, and because of that some of the calcium is retained but also lost in the urine. So you can very well see here that the normal calcium and the calcium metabolism shown here, the resorption of bone that leads for calcium losing from the bone coming to the plasma, and formation of bone requires the calcium again, and reuptake of calcium from the plasma going to bone. But this requires a lot of other factors as well, like if the bone matrix is there, then only calcium can be deposited into the matrix. Similarly, ingestion of calcium in diet is not enough, absorption is required, and that absorption again depends upon hormones and calcium binding proteins that I discussed. So what is the mechanism of hypercalcemia? Why it develops, and what are the variables affecting calcium metabolism and target organs for calcium metabolism? So increased bone resorption can be one basic mechanism of hypercalcemia. Bone is losing more calcium, and because of the calcium level are rising in the ECF. And here the basic hormone responsible is parathyroid hormone. And definitely here the bones are losing it. And another mechanism can be increased renal reabsorption or decreased excretion from the kidney. And here the basic hormones which are important are vitamin D and calcitonin. And here the kidneys are basic target organs. Increase gut absorption from the calcium. So the calcium can also increase from absorption from gut, and that again depends upon the dietary calcium and phosphate values. Fibroblast growth factor 23 has been found important here, which can augment the absorption as well. Common causes of hypercalcemia can be the primary hyperparathyroidism. It results from the excessive secretion of parathormone and typically produces frank hypercalcemia. So this is because of the excessive secretion of parathormone from the gland. Primary hyperparathyroidism is approximately 2 or 3 times more prevalent in women than compared to male. So female predominance is there, and the disease is more common in females. The diagnosis of hyperparathyroidism in a hypercalcemic patient can be made by determining intact parathormone levels. So it is one of the battery of investigation. We require parathormone levels to be done. Primary hyperparathyroidism and various cancers account for the greatest percentage of all patients with hypercalcemia. So these are the two basic reasons. One, primary hyperparathyroidism, and second one, the cancers, various secondaries. Common medications are also there which can augment, which can change the calcium level, and they are more important, like the hydrochlorothiazide being a common thiazide diuretics used for the management of hypertension as well. Other thiazide diuretics prescribed for hypertension and edema also produces hypercalcemia. Lithium is one of the drugs which is used as antidepressant, can alter the level of calcium and it's very important cause because long-term use of lithium can also precipitate it. Excessive intake of vitamin D in the form of injection, which is very commonly prescribed by our orthopedic friends, and when injections are given, then hypervitaminosis D is possible. While giving orally, it rarely produces this. Even the hypervitaminosis of vitamin A or calcium can result in hypercalcemia. When lot of vitamin A is given or the calcium orally given in large quantities, that can also produce it. Malignancy-associated hypercalcemia is not very uncommon, and malignancy-associated hypercalcemia is the second most common after primary hyperparathyroidism. It can be presented as apart from paraneoplastic syndrome, that is parathyroid hormone-related protein, or due to direct bony metastasis. So it can be of two types. It is the most common in squamous cell carcinoma of the lung. The squamous cell carcinoma of the lung is one common cancer when the secondaries are seen in the bones. Head and neck, renal cell carcinoma, breast cancer, multiple myeloma, and lymphoma are others. Other less common causes of hypercalcemia may include lung diseases such as sarcoidosis and tuberculosis, rarely. Kidney failure is one common associate because in kidney failure again, basically hypocalcemia occurs, but sometimes hypercalcemia can also be seen. Hyperthyroidism and overactive thyroid, because of the working from the calcitonin, can produce the hypercalcemia. Being bedridden, immobilized patients, even for relatively short period, can produce hypercalcemia. So mobility is one important factor. Physical activity is very important factor. Paget's disease of the bone and multiple myeloma are other rare causes. So what investigations for management of hypercalcemia are needed? And in that, first I will look for the general examination like the serum calcium levels, after that, and serum phosphate levels, serum alkaline phosphate, serum parathyroid levels, serum vitamin D level, serum total protein, serum albumin, ECG. So these are the tests which are usually required to make a diagnosis. The specific investigation varies according to probable cause which we can think of, and because of that we can have other investigation depending upon the symptom of the patient and our thought mechanism. Treatment approaches after this investigation, and treatment of mild hypercalcemia can be different from the severe hypercalcemia. Patient with asymptomatic or mild symptomatic hypercalcemia, when the calcium level is less than 12, do not require immediate treatment. We can think of removing the cause and it will be treated by itself. However, they should be advised to avoid factors that can aggravate, including thiazide use and volume depletion, prolonged bed rest. These three precautions can be taken to avoid or further increase the hypercalcemia. Adequate hydratation recommended at least 6-8 glasses per day, and that is more important because hypovolemia will further rise the calcium level. So adequate hydration is required. Avoid using calcium-rich antacids. This is very common because these calcium-rich antacids can further aggravate hypercalcemia. Additional therapy depends mostly upon the cause of the hypercalcemia. That will vary from one cause to another cause. Moderate hypercalcemia requires treatment because asymptomatic or mild symptomatic individuals with chronic moderate hypercalcemia may not require immediate therapy, but in the long run they may require it. Regular monitoring of calcium levels is the first thing to be done. It is important to note that an acute rise to these concentration may cause marked changes in sensorium, which requires more aggressive therapy. In the patient, treatment with saline hydration and biphosphonates as described for severe hypercalcemia. In the next slide, I will describe it. Patients with calcium level more than 14 require more aggressive therapy, and here volume expansion with isotonic saline at an initial rate of 200 to 300 ml per hour that is adjusted to maintain the urine output at 100 to 150 ml per hour. So by that we can regulate the volume expansion, and we can judge whether the volume expansion is up to the mark or not. In the absence of renal failure or heart failure, loop diuretic therapy to directly increase calcium excretion is not recommended because of potential complications. So in the absence of renal failure or heart failure, loop diuretic therapy is not recommended. Administration of salmon calcitonin 4 international unit per kg and repeat measurement of serum calcium in several hours. It can be repeated every 6 to 12 hours. The dose can be repeated. The concurrent administration of zoledronic acid 4 milligram intravenous over 15 minutes or pamidronate 60 to 90 milligram for over 2 months, preferably the zoledronic acid, because it is superior to pamidronate in reversing hypercalcemia related to malignancy. In malignancy conditions, when the secondaries are there, this treatment is done. The administration of calcitonin plus saline should result in substantial reduction in serum calcium concentration within 12 to 48 hours. The biphosphate will effective by the 2nd to 4th day. So initially we start with it, then the biphosphate will start working, thereby maintaining control of the hypercalcemia. Additional, more aggressive measures are necessary in the rare patient with very severe symptomatic hypercalcemia. To save the life, we are required to do that because the patient will lead into coma. The hemodialysis should be considered in addition to the above treatments in patients who have serum calcium concentration above 20 or 18 milligram per deciliter and neurologic symptoms but a stable circulation, are in those with severe hypercalcemia complicated by renal failure. Then definitely dialysis or hemodialysis is the answer. Preventing the recurrence of hypercalcemia, because once treated it can reoccur, and the follow-up therapy is aimed at preventing the recurrence of hypercalcemia in patients with hypercalcemia malignancy. Progressive hypercalcemia will inevitably accompany tumor progression, and therefore the underlying disease causing the hypercalcemia should be treated if all it is possible. Most of the time may not be possible because we can't do anything for cancers. Many patients with malignancy may also have metastatic bone disease and will have to receive IV zoledronic acid or pamidronate every 3 to 4 weeks as part of their treatment to prevent skeletal complications and further aggravate the situation. So this is the dosing schedule written here, and you can see very well the dosing schedule of normal saline, IV route, and how to monitor and how to do it written here. Similarly, furosemide can be given, especially in renal failure conditions, and the calcitonin can be given, and you have to monitor for allergic reactions, especially should be given after a skin test of allergy. Zoledronic acid 4 milligram intravenous over 15 minutes every 2 to 4 weeks, and drug of choice for malignancy associated hypercalcemia, and we have to be cautious with chronic kidney disease and myeloma. The silacalcet 30 to 90 milligram BID or QID can be given, and taking with meal is a better option, and we have to monitor for parathyroid hormone, calcium and phosphate levels at least 12 hours after dose. The gallium nitrate 200 milligram per meter square per day and intravenous should be avoided in renal failure, and monitoring of creatinine, phosphate and complete blood count is required during this therapy. Dialysis is the choice I have already stressed upon, when the and hemodialysis is the choice. Even PD can be done, and we have to watch for hypercalcemic crisis or refractory hypercalcemia, and usually we have to be very cautious in the conditions like this. Calcitonin has certain advantages, like it is safe and relatively non-toxic, although relatively weak agent. It works rapidly, lowering the serum calcium concentration by a maximum of 1 to 2 milligram per deciliter, beginning with 4 to 6 hours. It's most useful with hydration. Limitation is the efficacy of calcitonin is limited to the first 48 hours. So initially it may work, but after that may not work. Even with repeated doses, indicating the development of tachyphylaxis, perhaps due to receptor downregulation. Biphosphonates, they are effective in treating hypercalcemia resulting from excessive bone resorption of any cause, maybe primary hyperparathyroidism. They are more potent than calcitonin and saline for the patient with moderate or severe hypercalcemia. But their maximum effect occurs in 2 or 4 days, so that they are usually given in conjunction with other therapy because they will take time to have their effect. But they do have potential nephrotoxicity. We have to keep this in mind. So that was my presentation. I would like to thank you all for the patient listening.